introduction. Good afternoon, everybody. First thing, I just want to start off by saying big thank you to everybody, especially those that work behind the scenes to make the summit today a big success. I'm super excited to be here to speak with all of you today. I'm not exaggerating that right behind probably going on vacation with my family or going on a nice long bike ride, that talking about antibiotic stewardship is just one of my absolute favorite things to do. Sorry, forgot about that. And if you don't believe me, there's several of my coworkers here that would probably back me up on that statement. So today I just want to share everybody some of the highlights that are from my own journey as a consultant pharmacist as we are getting involved in the world of long-term care antibiotic stewardship. So for starters, just to give a little more background on me, so as was in my introduction, I graduated from pharmacy school of the University of Nebraska Medical Center, class of 2018. And then at the same time I was going to school, I was an intern for community pharmacy, which is a long-term care pharmacy in Gretna. I had always had an interest in the field of infectious disease. I think I can probably trace that back to looking at slides through one of those cheap microscopes your parents buy you as a part of a science kit when you're a kid. So this interest in microorganisms meant that whenever we had lectures about antibiotics, antifungals, or antivirals, I was always really tuned in. After exploring some ideas of if it was possible to blend those interests with my growing interests in long-term care pharmacy, it didn't take very long for antibiotic stewardship to really come to the forefront as a career path for somebody of my interests. Thanks to the help and guidance from Dr. Scott Bergman, who's moderating the session next door, I was able to put together a research project as a student that looked at benchmarking metrics of antibiotic use for some of the interested facilities at community pharmacy services in 2016. That project would help be one of the puzzle pieces that kind of needed to fall into place that would kind of be a launching network for the system that community pharmacy would implement later on. Ever since after passing my boards, I started working at community pharmacy as a pharmacist, with at least part of my schedule being dedicated to being a consultant. And then over my career there so far, I've had the absolute privilege of helping the development and implementation of our antibiotic stewardship interventions. So one of the questions that needed to be answered early on in this journey was, is a long-term care pharmacy even in a position to help with this new CMS requirement? My argument was that absolutely, yes it is. When looking at the resources that a long-term care facility could potentially draw from in order to implement what was being asked, it seemed obvious to me that a consultant pharmacist should be a major part of the solution. Many nursing homes operate under some degree of financial strain, so that while ideally it would be amazing if every facility had the resources and the budget to contract with an infectious disease expert to implement and operate stewardship programs, we could see that this was maybe not the most realistic solution for a large group of facilities. Even before the COVID-19 pandemic, staff turnover was a major obstacle that many long-term care facilities wrestled with each month. With this new requirement, it was likely that the competition to hire and keep nursing staff skilled in infection prevention and infection control was only going to get more fierce. So this begs the question, who are we left with? Is there anyone left in the building with the skills that could help with this new requirement? What about the consultant pharmacist? Long-term care facilities are already contracting with consultant pharmacists for their monthly medication regimen review, as well as other services to ensure proper medication use within the facility. So why not the consultant pharmacist? This question was posed to some of the leadership back at the pharmacy during the early stages of planning for this project. Luckily, the leadership agreed with the view that a pharmacy provider could add value to its facility partners in this area of stewardship. I can't stress enough how important that this leadership support was, as without it, the necessary time, consultant pharmacist training, and empowerment to take a key role in antibiotic stewardship moving forward would likely not have been possible. So once we established that we wanted to explore this new avenue of service, we had to start answering the question of how we were going to do this, and in order to do that, we needed to know exactly what needed to be done. Luckily, as outlined in just a few talks ago from Dr. Cabani, we had the CDC guidance documents and the core elements of antibiotic stewardship to look to. These together read kind of like a how-to document that provided much of the guidance that we were looking for. We decided that the following core elements accountability, drug expertise, actions to improve use, tracking, reporting, were all things that fell under the scope of a consultant pharmacist's realm of expertise. We felt confident in our ability of at least partially fulfilling these core elements for facility antibiotic stewardship programs. This, combined with having access to the antibiotic dispensing data as the dispensing pharmacy, meant that we could also provide antibiotic use metrics such as antibiotic starts and days of therapy to help fulfill the tracking requirement. Once we were confident that we had the bones of something useful, we set to get the word out to all of our partners and ask if they would be interested in participating in a new joint antibiotic stewardship project. And we were met with 32 facilities that said yes, they would like to collaborate on this going forward. So once we had established that there was interest from both sides, the pharmacy and the facility, things really started springing into motion. Around this time, a meeting was set up between community pharmacy leadership and interested parties from Nebraska Medicine with the Department of Infectious Disease, and it was decided that these two entities would collaborate on this venture as well. Community pharmacy would receive this antibiotic stewardship program training for their consultant pharmacists from a team of Nebraska Medicine physicians and pharmacists. Nebraska Medicine would also help us build the interventions to improve antimicrobial use at the facility level to implement. These interventions would come in the form of a nursing communication tool called an SBAR, which has been touched on in previous talks, and letter templates to be used by the consultant pharmacist during the monthly medication regimen review. These letters were to be used for courses of antibiotic therapy determined to be potentially inappropriate by the pharmacist. The Nebraska Medicine team also put together a quick reference binder that would go to the participating facility's IP nurse and help them guide through implementation. This binder also housed the physical notes from each of the monthly antibiotic stewardship meetings that would take place. In return for all of this, with the permission of participating facilities, the Nebraska Medicine team would have access to the data collected during the project to analyze for publication. Once this relationship was established and all the trainings were done, and the tools were developed, we moved ahead with implementation. The goal was to analyze how many of the stewardship core elements were satisfied, as well as if there was any significant reduction in antibiotic starts or days of therapy per 1,000 resident days at the end of the study period. So diving into some of the details, these are some of the specific interventions that we used. The first one was the monthly antibiotic stewardship program meeting. So in our model, the consultant pharmacist was to make every effort to arrange a meeting with at least an infection preventionist, but also potentially the director of nursing or medical director. The goals of the meeting were to discuss barriers of success of the program, and as well as offer any paths forward for these perceived barriers. The consultant could take this time to discuss any patterns or specific problem areas in antibiotic prescribing discovered upon the medication regimen review. And this meeting was also to be used as an opportunity to express to the IP the importance of obtaining a facility-specific antibiogram. If the IP was having any trouble with obtaining this antibiogram from the laboratory provider, the consultant pharmacist was also to offer assistance in doing so. The second intervention was our UTI SBAR. So this UTI SBAR tool was to be the topic of the very first antibiotic stewardship program meeting. The template was to be shared with the infection preventionist, and the goal of having all the nursing staff use this form to communicate potential UTIs to providers going forward. The consultant pharmacist was to monitor if the UTI SBAR tool was being utilized during their medication regimen review and report the adherence data back to the IP during each monthly meeting. Thirdly, is the monthly medication regimen review letters. And the consultant pharmacist was to review every course of antibiotics in currently active residents since their last MRR and offer guidance directly to the medical providers via MRR letters. When courses of therapy were determined to be potentially inappropriate, a letter would be generated. Both the number of appropriate and potentially inappropriate courses of antibiotics were to be tracked and then reported back to the IP during the monthly meeting. And then lastly, the consultant pharmacist was to share the tracking data, the antibiotic starts and days of therapy that was collected from the central pharmacy software. These numbers, combined with census information from the facility's EMR system, allowed the consultant pharmacist to provide metrics of antibiotic starts and days of therapy per 1,000 resident days, which is what the recommended tracking metric is by the CDC. So as our consultant pharmacists performed these interventions at our enrolled facilities, we eagerly awaited for the results. And thanks to our friends at Nebraska Medicine who did all the statistical analysis, we received this great look into how impactful a year's worth of these interventions was. Of the 32 facilities initially enrolled, 27 submitted enough data to be studied and analyzed, and it was determined that the number of facilities that implemented all 7 CDC core elements increased from 0% at the beginning of the study to 67% by the end of the study period. In that same time, the median antibiotic starts per 1,000 resident days across all facilities decreased from 9.91 to 8.93, and the median days of therapy per 1,000 resident days decreased from 141 to 106. All these reductions were determined to be statistically significant. The conclusion was that the consultant pharmacist interventions played at least some part in successfully lowering the starts and days of therapy, as well as guiding over half of the facilities to implement all the stewardship core principles, or core elements, excuse me. So at this point, I'd like to share some of the actual examples of our interventions. Here's an example of the UTI SBAR template that was developed for the study and that we used. A lot of you will probably recognize this if you've been to the ASAP website. It is the exact same template that is still available there to use. Many of our facilities would change 1 or 2 things about the form before implementing it, but the assessment section where the McGear criteria are located remain untouched. This tool, or a lightly modified version of it, still stands as the primary antimicrobial stewardship intervention that we use today in our antibiotic stewardship programs. Over time, we've seen that the SBAR form can work wonders in reducing inappropriate antibiotic starts for UTIs, but we've also seen some of the more common issues that can occur with such a tool. Probably number one among the most common pitfalls with SBAR use is that a staff member marks the box that a resident met criteria, but then does not mark any of the McGear criteria in the assessment section. Instead, they opt often to write in the symptoms that have historically been used. Things that we've talked about earlier today, such as foul-smelling urine or increased confusion, that aren't listed among the McGear criteria, somehow find themselves written into the margins or anywhere that they'll fit. Almost as common is that the staff member fills out the form utilizing the wrong set of criteria. It's not uncommon to see that the box for new onset delirium is checked on an SBAR form for a resident that does not have an indwelling catheter. You'll notice that this is not listed among the criteria for non-catheterized residents. So an antibiotic started on either of these forms would be classified as inappropriate upon pharmacist review. The third common pitfall that we see is that a facility staff does not use the SBAR at the time of assessment, but instead fills it out later after the assessment and communication to a provider has already been done. While this is helpful from the standpoint of making sure that the proper symptoms are being documented in the resident chart, it ultimately bypasses the intention of the tool. To see the SBAR's full impact, it needs to be used as a guide to help the nurse assess the resident and communicate the concern to the provider. Filling out the form retrospectively just means that if the resident did not meet criteria, this is discovered after the concern has already been communicated and UA has likely been ordered. So while unfortunately I don't have any catch-all to really solve all of these issues that we found pop up with the SBAR, I do have some tips that can be helpful to target certain issues. Firstly, is that education and re-education on how and why we use the SBAR tools is really the best thing you can do and the best thing you can adopt on a regular basis. This can't be something that is brought up once a year and then left alone, as old habits are extremely hard to break. But consistent reminders and touch points with staff on good SBAR use will go a long way in helping to form new, better habits. For facilities that tend to struggle with mixing up the criteria, I'd suggest something as simple as adding some language on the form, something like in big capital letters, do not use this for uncatheterized residents. I'll admit that the difference between the two sections when you first look at it is pretty subtle. So a big visual indicator that really pops off the screen or the page can be a good guide in the event that staff has any doubt as to which section they should use. Lastly, if a facility is struggling with the issue of staff filling out the SBAR after the original communication takes place, I'd recommend adding SBAR compliance to the facility's internal quality improvement radar and performing normal, regular internal compliance checks. Since the pharmacist is already reviewing all antibiotic starts within the facility during each MRR, I'd suggest that you can lean on them to help assist the facility in assessing this compliance by checking any antibiotic start for UTI for an appropriately filled out SBAR as well. So moving on from the SBAR, I've got a few examples of some medication regimen review letters that we've used over the years. This first one is actually one of the templates developed for our joint project with Nebraska Medicine. I don't believe we kept track, but I'd venture to guess that this letter was probably the most used template during the study. The goal of this letter is to clarify with the provider retrospectively if a resident met any of the McGeer criteria for an antibiotic started for UTI. We would draft one of these letters anytime a consultant pharmacist could not find any charting of criteria at the facility that warranted an antibiotic start. The goal with this was to give the ordering provider some guidance as well as an opportunity to explain if the antibiotic was indeed warranted per McGeer criteria. This second letter is an example of one that I personally use quite often at the start of our interventions, but thankfully have not had to reach for quite often as lately. In this specific case, the resident had received a week of fluoroquinolone antibiotic ciprofloxacin for the treatment of an uncomplicated UTI. The antibiotic was started based on the results of a UA and a resident's symptoms, which did in fact meet McGeer criteria for UTI. But unfortunately, there was nothing obvious upon review of the chart that should have influenced a provider to pick fluoroquinolone over established first-line agents, nitrofurantoin or Bactrim. This third letter I chose to include because it is something non-UTI related, since it seems like that's all we've really touched base on so far. But this is another one of my personal letters that I've drafted for a resident who is receiving doxycycline, 100 milligrams twice daily, with the instructions to continue indefinitely for recurrent cellulitis. Now, while there are some cases that the data suggests that prophylactic antibiotics may have good risk versus benefit, nothing from this resident's chart suggested that they had experienced anything more than one diabetic foot infection prior to admission. In addition, doxycycline also had the potential to cause harm in this resident by way of a drug-drug interaction, as the resident was also on warfarin. I felt that it was pertinent to bring this one up to the provider's attention and just ask them to review the case and to ensure that this resident's care was optimized. So for those consultant pharmacists in the room, I do want to share some tips for writing these sorts of letters that have helped me over the years. And the first thing is that I really try in all my communications to avoid the term inappropriate, which seems kind of crazy because we've been talking about inappropriate antibiotics this whole afternoon. What my goal with these letters is not to call out a provider or to criticize clinical decisions. Our goal is to help guide and offer support to providers so that we can all offer our residents the highest quality care possible. Choosing to use a phrase such as the resident did not appear to meet X criteria according to documentation available upon my review is a much less adversarial way to ask for reasoning than to just say, this is inappropriate, explain. Secondly, don't be afraid to intervene in current therapy. I've drafted many letters the same day and sent them off to the providers, but then not waited till I was finalizing my report. Usually in this case, I'll leave a nursing note in my MRR report that will go to the nursing staff to let them know I sent a letter that same day. And it usually asks for follow-up if no response is received by the time I close my review. Thirdly, I always try to offer relevant references to back up what I'm saying in the letters. IDSA is my personal favorite, but there's other resources out there as well. And lastly, something that we found that was very useful is adding a header to the top of any antibiotic stewardship related letters, something along the lines of, you're receiving this letter as a part of a long-term care facility's antimicrobial stewardship program. Something like this will indicate that the letter is part of a larger quality improvement effort, which usually adds some weight and credibility to it. A nice caveat too is that it will help you and the IP quickly identify the ASP letters in the finalized regimen review report or the resident chart. All right, then next I have some real examples of some of the tracking reports that we share. So this specifically is the type of tracking that could be achieved by a consultant and a dispensing pharmacy that are under the same roof. On the left, you can see an example of a chart put together for one of our facilities that tracks starts and days of therapy per 1,000 resident days. These metrics are updated and provided to the IP at this time quarterly to help fulfill their tracking core element. These metrics are most useful when looking at long-term trends. Yearly means and year-to-date means help trend if a facility is reducing antibiotic use or not. Looking at starts and days of therapy versus helps the Antibiotic Stewardship Committee determine if there are any specific problem areas that need targeted. For example, if you get the sense that you're seeing a lot of increased antibiotic use for UTI, you can go back to the data and try to back this up. In addition to the dispensing report on the left, another powerful report that our consultant pharmacist team can implement is the appropriateness assessment report on the right. This chart is an example of all the appropriateness assessment data that the consultant pharmacist gathers during their MRR. This can be tailored to each facility's specific needs, and for instance, this facility wanted to see their breakdown of starts inside the facility versus outside the facility, and this is also where they chose to have their SBAR compliance reported. It's pretty hard to try to sum up all the lessons that our team and the nurses that we worked with learned during this project, but we attempted to try and classify as many of the perceived barriers as we could. As a part of the study, we asked that all the consultant pharmacists discuss what the perceived barriers to ASP implementation were at the very first antibiotic stewardship meeting of the study, and then again at the very last stewardship meeting of the study. The ASP team was asked to give at least 3 perceived barriers if they could, and were welcome to list more. The results of those discussions yielded a solid top 4, which were lack of buy-in from clinicians, family or resident pressure, lack of staff buy-in to utilize the SBAR tool, and time constraints on the facility staff that prevented training on the SBAR tool. None of these should come as a surprise, I don't think, to most people in the room. These perceived barriers continue to prove difficult for us to try and overcome even today, especially with the COVID-19 epidemic has put an enormous time and labor burden on our long-term care facilities. I'm certain that if we were to re-ask this same question today, that time constraint would probably take the lead as the main barrier. My best advice for facilities that are looking to follow a similar model that we outlined here for implementing antibiotic stewardship programs is to be persistent. Our study took place over the course of a year, and it was hard to put in all the work not knowing if it was making a difference. Have faith that the data is on your side and that slow change for the better is still change for the better. Try everything you can to secure buy-in from the nursing staff, as it is absolutely invaluable. So many issues can be tackled right away at the assessment and communication step, and this makes it easier to do everything else that you need to do to make sure the antibiotic stewardship program is healthy. Be constantly on the lookout too for ways that you can improve your interventions. Some things that are kind of easy to try to get done are to make sure that your consultant pharmacist has electronic lab access to help you with cultures when you need them to, as well as exploring any non-pharmacological interventions to help with people that seem to struggle with chronic antibiotic cases. So if you're a consultant pharmacist looking to get more involved in antibiotic stewardship, I want to arm you with some of the knowledge that the challenges that you might face along the way. Probably the biggest of which is staff turnover. So it can certainly be defeating when you have a good working relationship with a facility and an IP, and then you get the notification that the IP is no longer at said facility. My best advice here is to view every one of these sort of situations as an opportunity on 2 fronts. The first one is that you get to start a brand new relationship with a new partner in antibiotic stewardship, and they're going to bring their own perspective, which may prove helpful for you in the program. And second, the IP that is leaving most likely has seen how much support that you can offer as a consultant pharmacist and will be more receptive to consultant pharmacist help at their next opportunity. And how can we talk about challenges in long-term care without talking about COVID-19? I don't need to beat this drum too much, as we are all keenly aware of the burden that the pandemic still places on us every day. But one thing that I see uniquely important to consider when it comes to consultant pharmacy is that during the height of the pandemic, many consultant pharmacists worked fully remotely. In many cases, this has complicated the establishment of regular routines and relationships between the consultant and other members of the stewardship team. This is something that we're still working to try to get recovered from today. Be prepared to spend some additional time on your regimen review as well, especially at the beginning. I'm not going to lie and say that we were able to increase our stewardship roles at our facilities and also not increase the amount of time it took to perform our MRRs. But we made the decision that the quality of our services was increased so much by this venture that the additional time is ultimately worth it to our facilities. I try to remind myself how much nursing time we're saving simply by doing the tracking. And lastly, be prepared to receive some occasional negative feedback from providers on your MRR letters. Don't let it discourage you. It's happened to all of us. So the last thing I want to talk about is kind of some of our plans for the future. So in addition to continue to reestablish our in-person presence and meetings at our facilities, we're looking into expanding our SBAR interventions, both into skin and soft tissue infections and respiratory tract infections. While UTIs dominated infections resulting in antibiotic starts during our study period, taking 40% of the share, SSTIs and RTIs combined to make up another 43%. So these naturally became the next target for further SBAR implementation. Another intervention we hope to someday explore with our facilities that was brought up in other talks before this is the antibiotic timeout tool, which would force a review of every antibiotic course 48 hours after the initial start to see if there's any additional information that could influence if a course should continue. I'm also excited that community pharmacy is kind of launching its own nurse consulting service, which may provide an opportunity and possible avenue for offering some assessment and prevention training as well. And that is all I have. So thank you for your time and attention, and happy to answer any questions.
From a historical standpoint, follow up with those facilities that you did this study with?
From a like a data standpoint, like
yes.
Seeing if we're so. Yes and no. I mean, we're still in those buildings, most of them performing these same sort of interventions, and there was some interest in looking at how the core elements are holding up after some years through the pandemic and things like that. I don't know if that data has actually been collected and shared at this point yet, though. Yep.
Are there any questions for the So say you draw, or the UA was drawn, and the person has a catheter and no symptoms. The UA was drawn for a pre-op physical. The prescriber decides to prescribe antibiotics, but again, there's no symptoms, nothing. They don't meet Neukirch criteria. And I put on my big girl shorts and said, hey, doc, they don't need this. Like, do you really want them to be on this antibiotic? And they still prescribe it anyway. What then?
That is a fantastic question. I think at that point, the best that you can do as the I'm assuming you're coming at this from a pharmacist perspective, or DON. Okay, perfect. So I mean, if you want, you can try to get your consultant pharmacist on board too. Sometimes that can carry a little more weight. It's like, hey, do you mind reviewing this case with me? Do you agree with me that this is not necessarily appropriate? And then you can kind of put a joint letter out or joint communication to the provider. That would certainly be something to try. But really, if that's, you exhaust those options and your provider is still saying, no, I want the treatment, at that point, that's really all that we've seen that we can do. So, yes,
Great,
Dr.
great talk. Thank you. Thank you
Thank
very
you.
much. Sorry, just a quick one, and then we'll finish. You know, have you seen provider behavior change, you know, over the period of time, you know, after you are sending these letters out? Any thoughts?
Yeah, so absolutely we've seen behavior change from, especially before the study period through, like, then they kind of received lots of letters from us for about a year. And we could kind of see that, especially the providers that are making kind of their living as long-term care specific, either medical directors and their advanced practice personnel, they have reined in their durations and selection of first-line agents pretty well. I'd say right now the folks that we struggle with more are for like long-term care residents that have their own provider that they see outside of the long-term care network. Those folks that are still kind of more in a community treatment mindset sometimes are less likely to be up on what we're sending letters for. Those are the ones that we typically get kind of the more adversarial reactions back from. So, yep.